At the other end of Indonesia in Lombok, we've made sure that we've worked with religious leaders, mostly Muslim, to make sure they understand the nature of our work with young people and that they support it. Young people like interesting ways of delivering messages. So in the Pacific, we've supported a 10-part soap series called Love Patrol. And that's been shown in most Pacific countries and been translated and shown in Papua and West Papua provinces of Indonesia. In an evaluation after the series, you can see the very high numbers of people who reported having watched Love Patrol. Prevention of mother-to-child transmission has been and remains tracked in a clinical box. The reason it's important to have a comprehensive approach to this is that 2 years ago, 40% of new HIV infections in Thailand and more than a half in Cambodia were among married women who don't live in any of those boxes and who are most probably infected by their husbands. Two surveys we did in Vientiane in Laos found that almost 100% of young men and women felt that it was unsafe to have sex during the latter part of pregnancy and in the postpartum period. And this, we found from focus groups, meant that men commonly had extramarital sex during this 8 to 9 month period. Modelling in Thailand shows that back in the early 90s, when incidence of new infections was high relative to prevalence, 58% of HIV infections in infants were due to new maternal infections. That means their mothers had been infected just before, during, or just after pregnancy, and their HIV tests would have been negative, even if they got to an antenatal clinic that did testing. That figure decreased 26%, but it's still substantial as incidence decreased relative to prevalence. So we promote a more comprehensive approach that includes the primary prevention of HIV infection in both parents, especially during pregnancy, when women we know physiologically are more susceptible to being infected. I think this is an excellent graph in that it shows that the decline in paediatric AIDS in Thailand was not primarily due to the introduction of testing and providing antiretroviral prophylaxis. If you look at the white line, that is prevalence among young men, okay, 21-year-old military conscripts. You'll see there's a gap of about 5 or 6 years to the peak in infections among children. And then you'll see a steady decline that mirrors the decline in prevalence among young men, which was due to the promotion of condoms. And it wasn't until here, 2001, that testing and antiretroviral prophylaxis was introduced, which led, of course, to an even more accelerated decline. So preventing HIV in men is probably the most effective way of protecting women and their children. We've had a pilot program in Vientiane in 12 sites where men are encouraged to come to both antenatal and postnatal care. And to our somewhat surprise, within 6 months, more than 60% of the male partners of women attending those clinics did come and had both couple counselling and gender-separate group counselling on the safety of sex during normal pregnancy, on the need to use condoms in extramarital sex. And we took the opportunity to include other important messages to involve men more in their partner's pregnancy, including information on early signs of labour, complications, and infant nutrition. We've just started a much larger study of the efficacy of this approach in Indonesia, funded by the Ford Foundation. Another box, IDU. The emphasis when talking about drugs and HIV has almost always been on injecting drugs, and certainly that's one of the most efficient ways to infect someone. But the use of drugs in general, particularly marijuana, the opiates, ecstasy, and amphetamine-like substances, may also increase the risk of increase the chance of high-risk sexual behaviour. Drug use also affects the sex partners, families, and communities of users. You all know by now that injecting drugs such as heroin is very high risk if equipment is shared. But one of the main obstacles to reducing harm has not been the lack of an intervention or the lack of technology. It's been the fact that there are, in many countries, laws that prohibit both the possession of drugs and the exchange and even possession of clean syringes and needles. So our colleagues at CHR have worked with law enforcement officers in a total of 12 Asian countries to facilitate access by drug users to clean needles, syringes, and to drug substitution programs. In addition, Burnett has worked with governments to develop appropriate enabling policies and legislation to reduce drug-related harm in Malaysia, Indonesia, Vietnam, China, Burma, Iran, and Central Asia. In Indonesia, over the past 5 years, Burnett has promoted policies that support methadone treatment in prisons and comprehensive harm reduction and treatment programs that are delivered through the public health system. And they have also been doing innovative research in PNG, Laos and Fiji to document the relationship between drug and alcohol use and vulnerability to HIV and STIs. Recently, when I was in Laos, I met 24 very interesting young men and women who were all said they were ex-drug using, though I suspected that some of them were still using. And these peers were recruiting participants into a very large survey of drug-related risks. So I'd just like to go back to working with women who sell sex and how we approach this. We believe that health promotion for women who sell sex is most effective when it's actually carried out by women who have or are still selling sex. Another problem is women who sell sex may not be able to get to service providers, or if they do, they may experience judgmental, negative attitudes. So in Chimoio, Burnett, in Mozambique, Burnett supports a program with a sex worker NGO called Omesh. They do outreach, as an example of their street theatre, as well as supporting a night clinic where sex workers can access and receive sympathetic services. And this is in a place where the HIV prevalence is around 20%. In Laos, unlike Thailand, there are no brothels. Women who sell sex are known as service women. They usually work in entertainment venues such as beer shops. Their prevalence is a lot lower than it was among sex workers in Thailand 20 years ago, but it is 1 to 4%. It is significant. And our program supports the training of peer educators who are trained by a Thai sex worker group called Empower that speak Lao, understand Lao, and also engage men in the training process. A lot of emphasis is put on sex workers without recognising sometimes the obvious that it's men who infect sex workers who then go on to infect other men. So a study we did in Vientiane found that in the first 6 months of 2004, about a third of men paid money for sex. And it was much more common among married men. So half of married men and about a quarter of unmarried men paid for sex. The unmarried men said they didn't mostly need to pay. They could go out and find sex partners relatively easy. So US government funded a project that they called the Clients and Service Women Project. We call it the Men's Project, where Burnett outreach workers focused on the slightly older young men who were on salaries and were more likely to pay for sex. And these workplace programs were very successful. The photo on the right is a group of firemen at a fire station. In Papua New Guinea, we support a program called Tingum Light. It's an alternative to the so-called high-risk group approach. It's a high-risk settings approach.